I'm Mas Chaponda. I'm a lecturer in clinical pharmacology. I will be considering questions in clinical pharmacology, the first being questions relating to drug overdose. The first question relates to an 18-year-old woman who presents to the accident in emergency having taken an unknown amount of aspirin. Which of the following statements is true concerning salicylates poisoning? I'll give you some time to consider that. Right. I'm going to talk about the answers, but I'll talk about each one in turn. So tinnitus occurs at plasma salicylate concentrations of 200. That is wrong. It's usually at higher concentrations, greater than 400 to 500. Metabolic acidosis is the first acid-base disturbance. Again, this is not true. It may be in children, but in adults, they start with a respiratory alkalosis because of activation of the respiratory center. Hypoglycemia is common in adults. It is not. This is common in children. It is a very late feature in adults. Acidosis reduces the rate of salicylate transfer across the blood-brain barrier. Again, this is false. Acidosis actually increases the rate of salicylate transfer across the BBB. Multi-dose activated charcoal may be indicated in the management. It is indicated actually in aspirin because of enterohepatic circulation. You want multi-dose activated charcoal to be given. And so the true answer in this case is E. Moving on to the next question. Which of the following statements is true concerning the use of multi-dose activated charcoal? And I'll give you some time to consider this. Let's look at each of these answers in turn. So, it is not appropriate in the management of salicylate poisoning. It clearly is, and it's useful in salicylate poisonings like aspirin. It is unsafe in patients with signs of bowel obstructions, and I will show you an X-ray soon after this to say it is actually unsafe. If a patient has bowel obstruction, charcoal will cause constipation and exacerbate, therefore, the bowel obstruction. It is of no benefit in overdose of modified release preparations. That is wrong. It clearly is of benefit. In drugs with modified release or slow release, you would like to use multi-dose activated charcoal. Charcoal should be given every 30 to 60 minutes. That is wrong. It's really given every 3 to 4 hours. It is useful in paracetamol overdoses. It is not. Actually, multi-dose is not useful in paracetamol. What you want in paracetamol, in the first hour, you could give a single dose, and then it's useful. This slide really shows the point I was making, that if a patient presents with bowel obstruction, and you can see here small bowel obstruction, you would not give this patient multi-dose charcoal, because that would make that situation worse, because it would increase the constipation. Moving on to the next question, a 24-year-old presents to the local airport suspected of being a body packer. Which of the following statements is true concerning the management of body packers? Again, I'll give you some time here to consider this question. If we look at the answer, I'll just remind you what body packers are. These are patients, or these are subjects who smuggle drugs into airports or into the country by packing drugs into condoms usually, which they will swallow. So abdominal X-rays may not show the total number of packages swallowed. And this is true, that the X-ray may be useful, especially if there's a halo around the packages, and I'll show you a subsequent X-ray that shows this, but sometimes they may not be seen. Whole bowel irrigation is contraindicated. This is false. In fact, that is the management. You would want to give whole bowel irrigation to expel the condom and the drug packages. Gastric lavage may be indicated. Gastric lavage is dangerous and is never indicated in body package. What you may do is actually bring up the drug, and that might cause toxicity in those subjects. Similarly, patients who are asymptomatic on arrival in A&E can be discharged. That would be an error. What we would want to do is to keep that patient for observation until we have expelled all the drug. Paraffin laxatives are safe in these patients. That's a tricky question. Worth noting that laxatives are indicated, But paraffin here is not indicated because paraffin may cause the condom packages to melt, thereby releasing the drug and causing toxicity. Here, in this X-ray, I demonstrate, especially in the lower part here, you can see packets containing the drug, and that can be seen spreading out across to the right iliac fossa. There is actually drugs available and visible, but very difficult to visualize, and that's why the question pertains to the fact that sometimes you can miss these, and they're not always visible on an X-ray. We will now move on to the next question. So here, we have a 24-year-old man who's brought to A&E after he's been found collapsed in the street with hypoglycemia. Friends have commented that he has taken a quantity of unknown tablets a few hours before. Which of the following drugs could have been ingested and cause hypoglycemia? Again, I'll give you some time to consider that question. I think the important point here is hypoglycemia, drugs that cause hypoglycemia, hence the glucometer there. And I think the main drugs to consider here are obviously insulin and sulfonylureas like glibenclamide and gliclazide, which we already know by their mechanism would cause hypoglycemia. But other drugs to consider are propranolol, and the only correct answer here is C, a beta blocker, propranolol. Other clues, I suppose, that you would be looking for in a question is in a patient presenting with bradycardia and hypoglycemia. Theophylline, iron, prednisolone, and bendrofluozide, none of those cause hypoglycemia. I think for the exams, it's worth noting that the treatment for propranolol overdose would be, and hypoglycemia, would be given glucose or glucagon, and you would also give atropine if they were bradycardic. Moving on to the next question. Still looking at overdose. Here we have a 22-year-old woman who's brought into A&E after ingesting 20 tablets of paracetamol 8 hours earlier. What should her immediate management consist of? And I'll give you time to look at this question. I think when we're coming to look at the answer, the timing is very important. And this normogram, which is found in the BNF, it's referred to in the exams and in clinical scenarios, it's very important to note that we usually look at the 4-hour time point. And at 4 hours, we have the normal risk and the high risk line. The high risk line is where you would consider alcoholics or patients who are taking enzyme inducers. So here we're talking about epileptics, patients on phenytoin, carbamazepine, for example, patients with low storage of protein, so people with HIV, with cystic fibrosis, they would be considered on the high risk line, the lower line. So you would look at the 4-hour line and you look at the levels there. However, let's go back to our question. They have told us 8 hours, so way above the 4-hour time, and we've been told the quantity, 20 tablets. So let's look at our answers. What should be her management? Activated charcoal. Paracetamol and activated charcoal, it's usually only effective in the first hour, so that is wrong. Liver function test, prothrombin time, and INR, I think that is also wrong because these are late complications. Day 2, day 3 is when you'd be looking for derangements. Plasma concentration estimation, again, ideally you want that at 4 hours. This is at 8 hours, so that answer is wrong. Inform the local liver unit for the management of acute liver failure. This patient is not in acute liver failure. In 8 hours, you would not expect that. You would probably be doing D at day 2 or day 3. So the correct answer here is the immediate management is the use of N-acetylcysteine, which is the antidote for paracetamol overdose. We shall now move on and consider the next question. Still looking at drug overdose, question 6. A 16-year-old woman attends casualty 15 hours after ingesting 30 grams of paracetamol and 2 grams of dihydrocodeine. On examination, she is drowsy with a Glasgow Coma score of 15. Her pulse is 100, blood pressure is 110/66, and she has pinpoint pupils with a saturation of 96% on air. What is the most appropriate management for this patient? Again, let's look at these 5 options and consider them. Again here, the correct answer is N-acetylcysteine. I give you the oral preparation to remind you that in the exams it is the IV preparation that is effective. But let us consider each one. Naloxone first, at the bottom. One would have been led to naloxone thinking about the dihydrocodone, but actually we're told her saturations are 96% on air. So she is not compromised respiratory by an opiate. And so there is no indication for naloxone. I think the next best answer one would have thought about is activated charcoal. Again, 15 hours, a bit late. 10% dextrose infusion, this patient is not hypoglycemic, and paracetamol at this stage would not have caused hypoglycemia. That is a late complication. Gastric lavage, not indicated. IV N-acetylcysteine is the drug of choice. Again, the antidote for paracetamol overdose. I think this is a very difficult question to consider, important for the exams and important in the clinical setting. What is the primary mode of action of N-acetylcysteine? I'll give you some time to consider this. So N-acetylcysteine is used as the antagonist for or treatment for paracetamol overdose. It is not a dopamine antagonist. It is not involved in phase 1 induction. It's actually phase 2. So phase 1 is redox, reduction and oxidation by the cytochrome P450 enzymes. This is glutathione peroxidase, and it's actually a precursor of glutathione peroxidase. It is not a histamine antagonist, and it does not reduce the formation of nitric oxide. What it does do, it's an antioxidant, it binds to thiol groups and clears nitric oxides. So the correct answer is it reduces the circulation of toxic metabolites. The toxic metabolites being N-acetyl P-benzoquinone. It's a bit of a mouthful, but that's exactly what it clears. The next question, which of the following is characteristic clinical finding of opioid poisoning? I want you to consider this carefully because actually this is quite tricky if you look at all possibilities that have been listed there. There are certain points that I would like to bring out here. The first here is the obvious. Clinical finding that suggests opioid poisoning. A, pupil dilatation. We know that with opioids you would have pupil constriction. Hypothermia, that would usually be with barbiturates. Deep respirations, they're not actually deep. With opioid toxicity you have lessening shallow breathing. Bradycardia is a feature, and that would be the correct answer. Whereas sweating and lacrimation is opioid withdrawal. So someone who is having, basically, they're having withdrawal from the opioids. I want you to consider this mnemonic, sludge. This is important if you're looking at a patient not with opioid, but slightly different with organophosphates. These patients will present with, and I'll read sludge and I'll show you why that's relevant here. So that's sweating and salivation, lacrimation, urinary problems, that usually means incontinence, diarrhea or gastrointestinal upset, and eye signs. And the eye sign is not pupillary dilatation, it's pupillary constriction. So if this question talked about a small pupil and bradycardia and sweating and lacrimation, the answer we would have put down here would have been organophosphate poisoning. So a tricky but important question. Finally, the last question. An 82-year-old woman is being prepared for upper GI endoscopy to investigate a coffee ground vomiting, hematemesis essentially. After receiving intravenous midazolam, this is what you would use to sedate her for the procedure, she has a respiratory arrest. Which is the most appropriate choice of emergency treatment? I want you to consider these drugs. Coming to the answer, there is only one answer, and that's flumazenil. She has taken midazolam, which is a benzodiazepine. So B is obviously the wrong answer because diazepam is also a benzodiazepine. So that would make things worse. Naloxone is really for opiates. That is not what she has taken. She has taken a benzodiazepine. Dantrolene and neostigmine are used for anesthetics to reverse muscle relax, to cause those that cause muscle relaxation. And in this case, what she has taken is a benzodiazepine. I think there's a point to note here. If someone in the streets had come in having taken an overdose of a benzodiazepine, you would not give them flumazenil. That's because it has a narrow therapeutic window, and what it can cause are seizures or fits. But if you are doing it within a hospital setting where you've given a known quantity of, for example, midazolam, in that case, if they have respiratory depression or the respiratory arrest, indicated in this case is flumazenil. Thank you. That concludes lecture 1, which was focusing on drug overdose. In lecture 2, we will consider drug metabolism and the questions that pertain to drug metabolism. Thank you.